The clinical record is much more than just a file or an administrative obligation. In reality, it is one of the strongest pillars of modern medical practice. Through it, we document every stage of the care we provide, from the very first contact with the patient to their follow-up or discharge. But beyond simply recording data, the record organizes and provides traceability to the entire healthcare process. This ensures continuity. It means that any healthcare professional can review what has been done, what has been diagnosed, what treatments have been prescribed, and how the patient has progressed, all in a single document. And why is this so important? Because it not only guarantees quality and safety in patient care, but it also backs the physician in legal, ethical, and scientific matters. The clinical record is a vital source of information for research, for teaching, and for institutional evaluation. Let's think about this scenario. What happens if a patient arrives at the ER without a prior record and no one can reconstruct their medical history? In such cases, the risk of errors and duplicated treatments increases significantly, and the quality of care is compromised. The conclusion is clear. The clinical record is a living tool that speaks for us when we are not present. To understand the value of the clinical record today, we must look back. We must ask ourselves, when did humanity first begin to record its medical actions? Since antiquity, in civilizations like the Egyptian, Greek, or Roman, healers were already documenting. They recorded symptoms, treatments, and outcomes. They did this to preserve and transmit knowledge, but also to learn from their mistakes. This proves that documentation has always been an intrinsic part of responsible clinical practice. Later, during the Middle Ages, a shift occurred. Hospitals run by religious orders began keeping systematic records of the sick. While these were rudimentary, they showed a clear concern for leaving a record of the care provided. Back then, the concept of an individual file did not exist. Records were collective or institutional. The 19th century brought the rise of scientific medicine. With it, the record adopted a more ordered structure. It began to include the anamnesis, physical examination, diagnosis, treatment, and patient progress. In other words, the record evolved into an organized clinical tool. Entering the 20th and 21st centuries, the scope expanded. We added legal, statistical, administrative, and teaching functions. And of course, we gave way to digital transformation with the electronic medical record, which poses new advantages but also new challenges. We might ask, has digitalization facilitated medical care, or has it complicated the interaction between doctor and patient? It is a valid question. However, one thing remains unchanged. Proper documentation is still an essential part of the Medical Act. Now that we understand the value and evolution of the clinical record, we must ask, what is the minimum content a record must have to be considered complete and functional? According to NOM 004, SSA 32012, certain basic elements must be present in every clinical record, regardless of the level of care or medical specialty. Among them are, first, the patient identification data. This includes the full name, age, gender, address, and case number. These data allow us to individualize care and prevent identity errors. Next, personal and family history. This is key for assessing risks and understanding the patient's clinical context. Physical examination and auxiliary study results must also be recorded. These data do not merely reflect the clinical assessment, they substantiate therapeutic decisions, presumptive and definitive diagnoses. These must be noted clearly and updated as the case evolves. Indicated treatment and clinical evolution. These complete the patient's follow-up. Additionally, medical notes from consultations. Notes from other healthcare professionals participating in the care must be included. And very importantly, informed consent forms, especially when dealing with invasive procedures or complex decisions. Finally, upon discharging the patient, a discharge note, nota de egreso, must be drafted. This functions as a clinical summary, indicating the admission and final diagnosis, the treatment received, which should never be summarized vaguely as just medical management, and the patient's status at the time of discharge, among other data. What happens if one of these elements is not documented? The answer is clear. It can compromise the continuity of care and weaken the physician's legal defense. Therefore, every component must be recorded clearly, timely, and without omissions. The clinical record is not just paper or a digital file. It is an active part of the Medical Act and of professional responsibility. We have discussed the content of the clinical record, but now we must pause to ask a key question. What is the actual purpose of the clinical record in daily medical practice? The answer is that it has not just one function, but many. Its utility is multiple, transversal, and vital. First, there is its clinical function. Thanks to the record, we can provide continuous, precise, and orderly follow-up to patient care. It allows us to make informed clinical decisions, even if we are not the physician who initiated the treatment. It facilitates the continuity of care between shifts, between departments, and between levels of care. Second, its legal function. The record is documentary proof of what we did, how we did it, and why we did it. In a trial or administrative proceeding, it can exonerate the physician or, in its absence or deficiency, compromise them gravely. Third, the administrative function. The record allows for internal audits, quality reviews, institutional accreditations, and continuous improvement processes. It also serves to evaluate the productivity of clinical staff. Fourth, its educational function. It is a key resource for training students and interns. Studying real records helps them better understand the clinical process and fosters medical reasoning. And finally, its research function. From clinical records comes much of the evidence that sustains changes in medical practice. The information they contain is valuable for epidemiological studies, clinical trials, and case reviews. Let's imagine a scenario. Suppose we want to improve the diagnosis times for appendicitis in a hospital. Where would we look for data? The answer is obvious. In the clinical records, they allow us to identify bottlenecks, delays in decision-making, and areas for improvement. So yes, the clinical record is many things at once: a document, a resource, evidence. But above all, it is the technical and ethical reflection of the medical act. In this slide, we pause to consider a critical aspect: the medical legal importance of every single component within the clinical record. In medical practice, every note, every entry, and every signature carries independent probative value. This means that if a component is missing or poorly drafted, it can lead to legal consequences for the professional, even if the clinical care provided was flawless. Let's look at some examples. Patient identification data is fundamental. Confusing records, duplicating them, or entering incorrect data can result in serious errors and may even lead to civil or criminal liability. Medical notes and diagnoses. These serve to demonstrate that the physician acted with clinical logic in accordance with the lex artis ad hoc. In other words, they prove that a reasoned, evidence-based diagnostic process was followed. Informed consent forms. These document that the patient was duly informed, understood the risks and benefits, and accepted the procedure. If that consent is not recorded, legally, it is considered never to have existed. Medical orders and progress notes. These show how the patient was monitored. The absence of these notes can be interpreted as a lack of control, patient abandonment, or even negligence. And discharge notes are just as relevant. They serve to close the cycle of care and communicate with the next level of attention. Omitting them affects not only quality, but also continuity of care and the physician's legal defense. Let's imagine a scenario. A physician performs a transfusion perfectly, but the patient had previously refused the procedure, and that refusal was never documented. In court, there is no written record. What carries more weight? What the doctor claims, or what is in the file? The answer is clear. What is documented is what counts legally. So, this is not just about ticking a box. Documenting correctly is a way to protect the patient, and it is also the best protection for the healthcare professional. We now arrive at one of the most sensitive topics for any healthcare professional: legal defense in the face of a complaint, report, or lawsuit. The clinical record, when properly executed, is the most powerful tool a physician possesses to protect their practice. However, when it is incomplete, poorly written, or absent, it becomes their primary vulnerability. In Mexico, as in many nations, the burden of proof often shifts to the physician. This means that if there is an accusation of negligence, the professional must demonstrate that they acted in accordance with clinical standards. And how is that proven? Through the clinical record. This document must demonstrate that actions were taken following updated protocols and clinical guidelines. The patient was informed sufficiently and in a timely manner. There was adequate follow-up and continuity of care. The golden rule: all of this must be written down, because what is not documented legally does not exist. Legal certainty. A record with organized, signed, and well-structured notes provides legal certainty. It can be the difference between being exonerated or sanctioned, between defending oneself with evidence or facing a presumption of negligence. Let's consider a scenario. A patient suffers a complication after surgery. The doctor acted correctly in the OR, but failed to document that information was provided, that risks were explained, or that consent was obtained. In a trial, that lack of written evidence can be devastating. Conclusion. Therefore, beyond the technical aspect, the record is a means to protect professional integrity, clinical truth, and legal justice. So far, we have discussed the record as a clinical document and a legal tool, but we must also acknowledge its deeper dimension. The clinical record is a direct reflection of the ethical principles that guide our profession. Let's start with autonomy. Every time we record an informed consent, we are documenting that the patient was heard, that they understood their situation, and that they actively participated in decisions regarding their own health. Next, we have beneficence and non-maleficence. What does this mean within the record? It means that the interventions we record seek the patient's well-being, and that we avoid anything that might cause unnecessary harm. If we fail to document a critical intervention, if we do not record our clinical reasoning, we lose the opportunity to demonstrate that we acted to help and not to harm. Another principle is justice. The record must make it clear that care was provided without discrimination, that every patient was treated with equity, regardless of their economic, social, or cultural status. And no less important is confidentiality. The clinical record contains sensitive information, protected by both law and medical ethics. Its misuse, unauthorized disclosure, or improper access constitutes a direct violation of patient rights. The bottom line: every note, every signature, and every piece of data in the record must be created with ethical conscience, because it is there, in those pages, that respect, responsibility, and dignity in medical care become concrete. Knowing what a clinical record must contain is fundamental, but knowing how to draft it is equally critical. Because it is not enough to simply note down information, it must be done with quality, ethics, and technique. One of the first rules is that the record must be written with clarity and legibility. This implies strictly avoiding abbreviations, value judgments, or vague phrases. Every entry must be understandable by any professional who reviews that document. Furthermore, notes must be recorded chronologically and in a timely manner. Although routine operations often make this difficult, it is strongly recommended not to wait until the end of a shift to write down what happened in the morning. Retroactive or imprecise notes can be legally invalidated and, worse yet, cast doubt on the veracity of the documentation. Another key point: do not cross out, erase, or informally correct entries. If we make an error, a formal correction note, an errata, must be added, including the date, time, and signature. And speaking of signatures, every note must contain the professional's full name, license number, and position. This not only identifies the author, but also delimits their responsibility. Let's think about a very common situation. We find a note in the file that says, "Patient was explained what was necessary. All good." Does that note legally protect the physician? Can we assume there was informed consent based solely on that phrase? The answer is no, because that phrasing is ambiguous, non-specific, and lacks the minimum necessary data. The bottom line: documenting correctly is part of medical care. It is not a parallel or secondary task. It is a clinical act in itself, possessing clinical, ethical, and legal value. Up to this point, we have discussed what the clinical record must contain and how it should be drafted, but it is equally fundamental to understand what happens when this is not done correctly. A poorly integrated clinical record is not merely an administrative problem, it has serious implications on multiple levels. First, on the clinical level, the lack of clear and chronological information can lead to treatment errors. What happens if the next shift doesn't know the patient is allergic to a medication? Or if there is no note regarding a recent surgery? The patient's life can be at risk due to an incomplete record. From a legal perspective, a record that is illegible, unsigned, or full of omissions can be dismissed as evidence. This leaves the physician without backing in the face of a complaint or lawsuit. In this context, what is not written simply did not exist. On the administrative level, deficient records affect audits, certifications, and institutional evaluations. Poor documentation practices can even translate into the loss of sanitary accreditations or regulatory sanctions. And of course, there are ethical implications. Failing to record informed consent, omitting diagnoses, or failing to document progress implies a direct violation of the principles of autonomy, confidentiality, and dignified treatment of the patient. Common but dangerous errors. Practices such as retroactive charting long after the fact, copy-pasting identical notes day after day, or failing to sign what is noted, can have devastating consequences. Let's imagine a scenario. Picture a trial for alleged negligence where the record contains only 3 lines: no diagnosis, no progress notes, and no signed consent. How would we prove we acted correctly? What value would that record hold? The bottom line: poor documentation can be just as risky as poor treatment, and both are paid for with very real consequences. To close this session, I want to invite you to reflect from a broader perspective. The clinical record is not just a requirement. It is not merely an administrative burden, nor a formality to simply cover your back. It is much more than that. It is a living testimony of the commitment each of us assumes toward our patients and the medical profession. When a record is well made, it speaks for us. It shows what we did, how we did it, why we did it, and what the outcome was. But it also says something deeper. It says that we respected the patient, that we treated them with dignity, that we offered safe, evidence-based care, and that we were responsible with every clinical decision. A well-crafted record protects the professional in the event of controversies, guarantees continuous quality care, especially when multiple physicians are involved, strengthens trust in the doctor-patient relationship, and contributes to learning, both personal and institutional. In summary, the clinical record is an integral part of the medical act. It does not stand on the margins of our work, but right at its center. And for that reason, we must ask ourselves something essential. If the record spoke for you when you are not present, what would it say? That is the true measure of our responsibility.